Hello everyone. So yesterday we discussed about radial nerve. Today the topic that we are going to discuss is on median nerve. Again, a very important university question, very important topic clinically. Though the course is not going to be that complicated when we compare with radial nerve, but you are going to have lots of exceptions. So you need to follow the entire course very carefully, and you have to know the actions of the muscles of the forearm and also the hand. So only if you have an idea on the insertion and the actions of the muscles, the nerve and its clinical applications are going to be very simple. So kindly follow what I am going to tell for the next 35 minutes. Now, as said in the radial nerve, we are going to discuss the nerve under these three headings. So first is the root value, course, and the clinicals. And this is the picture given in 𝗏𝗏𝒻𝒃. So I'm going to have this as a reference. I have put lots of interesting pictures, very simple pictures, so that we get to understand the relation and the course of the nerve. And I will correlate that picture with this picture so that you'll be able to grasp things easily when you read from the textbook. Now, as I say, any topic, you should start with an introduction. And with respect to the nerves of upper limb, yes, you have to draw the diagram of as a beautiful network, that is brachial plexus. So what is the introduction that you will give here? Now, in radial nerve, you just said it is the continuation of the posterior cord, and you gave the point that it is the largest nerve of the upper limb and all that. Here also you have got a very short introduction. So if you appreciate, yes, roots, trunks, division cords, and this is my lateral cord of brachial plexus. Yes, this is my medial cord. Can you appreciate this Y-shaped structure? Yes. So from the lateral cord, you have got the lateral root of the median nerve, and from the medial cord, yes, you have got the medial root of the median nerve, both of which is going to fuse together to form what is called as median nerve. Yes, so the median nerve is formed, or it is going to arise from two roots. One is the lateral root from the lateral cord, and the other one is the medial root from the medial cord. Yes, and both are going to fuse together. So this is the introduction that you have to give. Yes. So what is the root value? So if you take this picture, yes, it arises from the lateral cord. As discussed earlier, the lateral cord is going to have the root value of C5 to C7. So all the branches arising from lateral cord is going to have the root value of C5 to C7. And if you take the medial root of the median nerve, yes, it is going to arise from the root value C8 and T1. So it has got C8 and T1. So altogether, if you take both of this, is what is going to form median nerve. Yes. Hence, the root value is going to be C5 to T1. So C5, C6, C7, C8, and then T1. But what is the difference between the radial nerve root value and the median nerve root value? In the radial nerve, as T1 was not constant, right? So I specifically mentioned this point, whereas in the median nerve, T1 is constant because it has got a root from the medial root. So this is about the root value of median nerve. Yes, very clear. Now talking about its course. So if you take this picture, as we discussed in the radial nerve, we have got four important sites to be discussed in the axilla, arm, forearm, and the hand. But the difference is the radial nerve began to give branches right from the axilla. So we had some branches in axilla, in the arm. So the course was very complicated. But here if you take, there are no branches in axilla and the arm. So almost right from the cubital fossa, the branches will begin. So understanding the relations of the nerve in the regions is very important. So let us start with the axillary region. Yes, so it's very simple. So if you take this one, yes, it is my axillary artery. So here I have got axillary artery. And can you appreciate? This is the lateral cord of brachial plexus. This is the medial cord of brachial plexus. So from the medial cord, there is a root that is arising. So this is called as the medial root. It is called as the medial root of median nerve. And this is the lateral cord, and from there a branch arises. So this one is called as the lateral root of brachial plexus. So as we all saw in the introduction, both of these roots are going to fuse together to form the median nerve. So if you appreciate the median nerve, as this is the median nerve, and how it is related to axillary artery is, yes, this is the only point that you have to include here. It is lying lateral to the third part of axillary artery. So it lies lateral to the third part of axillary artery. So this is the original picture. So I have just zoomed the axillary region and I have shown you here. So if you appreciate this picture, as this is the lateral cord, this is the medial cord, these are the roots, and the median nerve is going to lie lateral to the third part of the axillary artery. Yes, it's very clear. Now we are going to talk about the course in the arm. So if you take, for easy understanding, I am going to divide the arm into two parts. One is the upper half. So let me divide it here. One is the upper half, another one is the lower half. So if you take in the upper half, the median nerve does not show any deviation, meaning whatever relation it was there in the axilla, it is going to continue the same course. So in the axilla, it was lateral to the axillary artery. So it is going to continue along the same path. But only thing is you have to change the name of the artery here. Here it becomes brachial artery. So in the arm, in the upper half of the arm, the median nerve lies lateral to the brachial artery. So it lies lateral to the brachial artery. But what happens at the mid of the arm? So somewhere at the mid-humerus, can you appreciate this picture? Very beautifully given. The nerve is coming laterally and it is going to cross the artery. Can you appreciate this portion? It is going to cross the artery and it gets medially located. Right. So in the mid-humerus, the median nerve is going to cross the brachial artery and it is going to enter into the medial aspect of the arm. So what happens here is in the lower half of the arm or at the mid-humerus, the median nerve is going to cross the brachial artery and move medially and it enters into cubital fossa. Yes, it enters into what? It enters into cubital fossa. So cubital fossa was dealt as a separate session where we discussed about the boundaries, its contents, its clinical application and everything. So just to take you there, this is the slide I wanted to put in to explain or to quickly revise the contents of cubital fossa. Yes, you know the boundaries. Now what are the contents? Yes, it is MBBS. This is the acronym that you must know. If I start appreciating the contents of cubital fossa, from the medial aspect to the lateral aspect, I have got MBBS structures. So what are these MBBS? M stands for median nerve, B stands for brachial artery, another B stands for biceps tendon, another S stands for superficial branch of radial nerve. Superficial branch of the radial nerve. So these are the contents. Here he has given deep branch, never mind. So here we have got the superficial branch of the radial nerve as one of the content of cubital fossa. So these are the contents. Now if you appreciate the median nerve, it has crossed the brachial artery in the lower half of the arm and it has entered into the cubital fossa. So cubital fossa, we saw it lies medially. Now in the cubital fossa, it gives rise to certain branches. As to what muscles it gives? It gives branches to the superficial flexors as it gives branches to the superficial flexors. So what are the superficial flexors that you know as? So this is why I told you have to recap the muscles of the forearm and the hand. A superficial flexors includes four: the flexor carpi ulnaris, flexor carpi radialis, palmaris longus, and flexor digitorum superficialis. Yes, these are the four superficial flexors. Now, the median nerve in the cubital fossa is going to give rise to superficial flexors. Now, in the very beginning, I told you median nerve is full of exceptions, right? Now, will median nerve supply all the superficial flexors? No, it is not going to supply one muscle. Yes, what is that muscle? That is flexor carpi ulnaris. So except flexor carpi ulnaris, all the three superficial flexors, that is flexor carpi radialis, palmaris longus, and flexor digitorum superficialis, are supplied by the median nerve branches rising at the cubital fossa. Yes, I hope I'm clear till this, right? So it began, right? So we saw the root value lie lateral to the third part of axillary artery. In the arm, it was at the upper half, it was lying lateral to the brachial artery. Then at the mid-humerus, it crossed the brachial artery, it became medially, entered into cubital fossa and gave rise to these three branches, as we are clear. So this is the picture that I want to show you. So if you appreciate, yes, we have got three branches. These are the three superficial flexors. Now, I want to highlight just action of one muscle because it's very important, that is flexor digitorum superficialis. Yes, flexor. So it is going to flex something. Digitorum, so it is related to digits, superficialis. So this muscle tendons are going to mainly flex the proximal interphalangeal joints. Yes, which is going to flex the proximal interphalangeal joints, as the proximal interphalangeal joints are flexed by the flexor digitorum superficialis as a very important muscle. I just know this so that clinicals is going to be really easy for you, right? Now, what happens? Just appreciate this picture here. So the median nerve is going to give rise to certain branches at the cubital fossa. Then it leaves the cubital fossa. Is how it leaves the cubital fossa. It leaves the cubital fossa by piercing some muscles here. So what are these muscles? Yes, these are the pronator teres. Yes, these are the pronator teres muscle. So once it leaves the cubital fossa, it is going to enter into, or it is going to pierce the heads of the pronator teres. What it does, it is going to pierces the heads of pronator teres. But is that the only thing that it is going to do? No, it has got one more thing. The other thing that I want to highlight here is just observe the picture. When it pierces, just appreciate this portion. When it pierces the pronator teres, it is giving rise to a small branch here. Can you make out the small branches? That small branch is what is called as the anterior interosseous nerve. We saw posterior interosseous nerve, whereas in the last video, here we have got the anterior interosseous nerve. So when the median nerve is going to pierce the pronator teres, it also gives rise to anterior interosseous nerve. Yes, what is the role of anterior interosseous nerve? So just let's leave this part, just observe this. So this is my anterior interosseous nerve, and what does this anterior interosseous nerve going to do? Yes, it is going to supply certain muscles. What are the muscles that it is going to supply? One is the pronator quadratus. Then it is going to supply the pronator quadratus. Then it is going to supply flexor pollicis longus. Then it is going to supply the lateral half of FDP. What is FDP? Yes, it is flexor digitorum profundus. Now, which muscle was responsible for causing flexion of proximal interphalangeal joints? Yes, your answer should be tendons of FDS. Now, which muscle is responsible for causing flexion of distal interphalangeal joints? Your answer should be FDP. Right, flexor digitorum profundus is responsible for causing flexion of the distal interphalangeal joints, and FDS is responsible for causing proximal interphalangeal joints. Superficial is superficial located. So just imagine, just have an acronym that it is going to supply PIP, or you can remember one more way, FDP. So if you take the last letter of the muscle FDP, it is P. So P and P is not going to come together. So FDP is going to cause flexion of distal interphalangeal joints. FDS is going to cause flexion of proximal interphalangeal joints. This is how I remember. So I remember P and P is not going to coincide. So you can remember in either way, but this is a simpler way to remember, right? So FDP for DIP, FDS for PIP, right? So it is very, very important for you to understand the flexors of the fingers, right? Yes, so we are clear now. So what happened? Yes, the anterior interosseous nerve is going to supply, what are the muscles? Yes, pronator quadratus, flexor pollicis longus, and lateral half of FDP. So which is going to supply the medial half of FDP? Yes, it is ulnar nerve, right? So ulnar nerve will be taken in the next class. So there you will get to know, right? Whatever we have missed here is going to be supplied by the ulnar nerve. Just remember like this, right? It is very simple. So lateral half of FDP is supplied by the anterior interosseous nerve, which is rising when the median nerve pierces the pronator teres muscle. Yes, clear? Yes, very good. Now let us get to this picture. Now you take, yes, it has pierced the pronator teres, it had given anterior interosseous nerve. But what happens to the median nerve now, the main nerve? Yes, if you take, here he has given something called FDS arch reflected. So what happens is, yes, once the nerve pierces the pronator teres, it is going to go underneath a tendinous arch that is called as the tendinous arch of flexor digitorum superficialis. So if you appreciate, this is the, so flexor digitorum superficialis, all the flexors are going to arise from a common flexor origin, right? So it is going to travel downwards. So if you take, this is the tendinous arch of the flexor digitorum superficialis. So if you take the tendinous arch has been reflected and the nerve is being shown, which means what? The nerve is going to travel underneath the flexor digitorum superficialis. Yes, so it travels underneath the flexor digitorum superficialis tendon. So if you appreciate this picture, this is my tendinous arch. So it travels underneath the tendinous arch of flexor digitorum superficialis, right? So it is going to lie deeper in the muscles, right? Then what happens? So let me write the course here. Just a quick recap, right? So cubital fossa, I will tell the entire course at last, but then and there we'll just remember. So from the cubital fossa, it pierces the pronata teres. So from the pronata teres, it gets along the tendinous arch of FDS. So from there, it lies in the deeper aspect, right? Then what happens? Almost few centimeters proximal to the hand, right? So this is the carpal tunnel and this is my hand and this is my wrist region. Yes, this is my wrist region. So few centimeters proximal to the carpal tunnel and the wrist, the nerve is going to slowly emerge. So if you take it as being deeply placed, let's use a laser pointer. Yes, it was deeply placed. Then slowly if you take it is emerging from the muscle, right? So this is the muscle bulk. It slowly emerges from the muscle. Then can you appreciate it becomes lateral to certain tendons. What are these tendons? Yes, these are the tendons of FDS. Right. So from the pronata teres, underneath the tendinous arch, it lies deeper to the muscle. Then few centimeters proximal to the hand, the nerve is going to come laterally to the tendons of FDS. It comes laterally to the tendons of FDS. Now, once it comes laterally to tendons of FDS, what happens? So this is the wrist. Yes, the purpose of me putting this picture is not to confuse the location of wrist and carpal tunnel. Wrist is actually called as distal forearm, right? Now, where we have the radial prominence is not the wrist, right? The wrist is somewhere here. So it is a distal forearm. So this is my carpal tunnel. So all these structures in the carpal tunnel are mostly superficially located. That's why if a suicidal cut is made here, then the life becomes very serious. Now, I do not know how many of you have seen this movie 𝗏𝒦 2, all the Tamil viewers. There if you take the trademark of Bobby Simha was, he used to cut the flexor retinaculum of the leg and he is going to cut the carpal tunnel. Why he cuts there is because all the vessels and the nerves are superficially located. So if he is going to make a cut here, then it's a serious threat for the patient's life. Whereas if you take the love failure cuts, okay, love failure cuts, they all will be here. It is all a threatening cut, right? So we try to threaten our parents or we try to threaten our friends, right? We do all kinds of things when we get into some depression or something. So all those are suicidal cuts where it is going to be at the distal forearm and even above that. So there is no serious threat there, right? So that is the anatomy beginners. So do not try to confuse between the words wrist and the carpal tunnel. Both are different. Wrist is actually distal forearm and carpal tunnel is right over here, right? So you would have dealt about carpal tunnel in joints. Yes. So what happens is, why I told all that story of 𝗏𝒦 2 and love failure, everything is a very important point to note. Once the nerve is going to arise or it is going to be laterally located along the tendons of FDS, can you appreciate the nerve just before it enters carpal tunnel? So this is my carpal tunnel. If you appreciate, nerve is entering into carpal tunnel. Before it enters into carpal tunnel, somewhere here, it gives rise to a branch, right? Sorry. Just appreciate this. This is the median nerve. Before it enters into the carpal tunnel, it is going to give rise to a branch. So this branch is what is called, finally I came to my point, right? It's called the palmar cutaneous branch. Very important. I'll tell you in clinicals why I stressed on this point is, if an injury is at wrist, the presentation of the symptom is different. If the injury is at carpal tunnel, presentation is different. So this palmar cutaneous branch arises from the distal forearm or the wrist. right? It arises from the distal forearm or the wrist. So it goes superficially to the carpal tunnel. Can you appreciate it? Goes superficially to the carpal tunnel. Whereas if you take the normal nerve, it goes deeper into the carpal tunnel. Right? It is going to get into deeper aspect of the carpal tunnel, right? So tendinous arch, then lateral to the tendon of the FDS, then at the wrist level, it is going to give rise to a palmar cutaneous branch that goes superficially along the carpal tunnel. You have got the median nerve that goes underneath the carpal tunnel, right? And then it is going to supply the hand. So we see how the supply of hand is going to be. Now, we have already seen, right? So anterior interosseous nerve supplies 2.5 muscles, that is flexor pollicis longus, lateral of FDP, and then pronator quadratus. This was the cubital fossa. So the nerve is going to enter, or it is going, we have seen the relations here. And if you take it, is going to enter the hand now. So we will just talk about the palmar cutaneous branch first. Right? We'll talk about the palmar cutaneous branch here. Right? So what happens to palmar cutaneous branch? The palmar cutaneous branch, which goes superficially to the carpal tunnel, if you appreciate this picture, as it goes superficially to the carpal tunnel to supply the palmar aspect, of the lateral 3.5 digits. Yes, the dorsum of the lateral 3.5, including the nail beds, was supplied by radial nerve. Right? Now the palmar aspect of the lateral 3.5 is supplied by the palmar cutaneous branch, which arises at the level of the wrist, which runs superficially over the carpal tunnel of the median nerve, supplies it. See how beautiful the story is, right? Yes, very beautiful. So this is with respect to palmar cutaneous branch. Now, what happens to the median nerve that goes underneath the carpal tunnel? So if you appreciate, we have just seen the story of what comes above the carpal tunnel. This is the palmar cutaneous branch. Now what happens to the nerve that goes below, right? Below the carpal tunnel. Yes, what happens? If you appreciate, yes, this is the nerve that has come below the carpal tunnel, and what it has done is it has done certain things. After it enters into the palm, the first thing that is done, what it does is it gives to a branch called as recurrent branch. It gives off a branch called recurrent branch. Just observe how the branch goes like a curly hair. It has arisen, right? After its origin, it is curved, right? So it curves upward. So it has curved in an upward direction, and it is moving laterally. So if you take, this is the thumb, so this is the radial side. So the recurrent branch, after its origin, it curves upwards. Yes, can you appreciate? Yes, it curves upwards and it moves laterally. It does so to supply the thenar muscles. Yes, to supply the thenar muscles. So what are the thenar muscles it is supplying? Yes, you have got appendix pollicis, adductor pollicis brevis, flexor pollicis brevis. So these are the three thenar muscles. So the recurrent branch, after its origin, curves upward and laterally, moves to the thenar eminence, where it's going to supply all the thenar muscles, right? And then what happens to the remaining nerve? Yes, if you take, the nerve is going to predominantly divide into two branches, right? So if you appreciate, it has divided into two portions, and each of these is going to give rise to 3 palmar digital nerves, right? So if you take all together, you have got, if you take, you have got 5 palmar branches, 5 palmar digital nerves, right? So these 5 palmar digital nerves is going to supply, the lateral 3.5 digits of the palm, except nail bed. I am sorry, I told that the palmar cutaneous branch does so. I am really sorry. The palmar cutaneous branch does not do this. It is going to supply the skin over the thenar eminence. So we saw I'm really sorry, the recurrent branch is going to supply the thenar muscles, whereas the thenar eminence, that is the muscle, is going to form a major bulk over there. The skin over the thenar eminence is supplied by the palmar cutaneous branch. I am really sorry for my confusion. Yes, the 5 palmar digital nerves is what is going to give sensation to the lateral 3.5 aspects of it, except the nail beds, right? So we have got totally 5 palmar digital nerves that is going to give rise to lateral 3.5 digit skin sensation, and it is also going to supply the first and the second lumbricals. So at the end, there's recurrent branch. Then we have got it divides to 3 palmar digital branch, which in turn gives rise to 2 palmar digital nerves, right? So this is one branch, this is another branch, this is another branch, and we have got totally 3 branches, which in turn gives rise to 2 branches. So totally we have got 5 palmar digital nerves, right? And additionally, we have got nerve to first lumbrical and then second lumbricals. So this is the entire course. So just to quickly revise, in the axilla is what we saw. Just follow me. I'm not going to show you the picture. You're going to visualize the pictures. Yes, in the axilla, it was lateral to the third part of axillary artery. Never mind my handwriting. It was lateral to the third part of axillary artery. So this was with respect to axilla. Then in the arm, it was initially lateral to the brachial artery. Then it crossed at the mid-humerus. Yes, I'm just writing the important clinicals, right? Important anatomical sites. It mid-humerus, it becomes medial and it is going to enter into cubital fossa. Just refer to the branches which I have told what happens in cubital fossa. Then from the cubital fossa, it pierces pronator teres. So where it is also going to give rise to anterior interosseous nerve. Then it is going to go behind the tendinous arch of FDSS. Remember the picture, remember the picture. Then 5 centimeter proximal, it comes to the lateral aspect of the tendons of FDS. Yes, it comes to the lateral aspect of tendons of FDS. Then it gives rise to the palmar cutaneous branch. Here I made a mistake. Do not make that mistake. It gives rise to the sensations over the skin of the thenar eminence. Then the median nerve goes under the carpal tunnel. We have got recurrent branch which supplies the thenar muscles. Then we have got palmar branches which give sensory innervation to the 3.5 aspects of the hand as well as nerve to lumbricals, first and the second lumbricals. Yes, so this is a very short course. I have not included the branches. So branches of the cubital fossa. You have to talk about the branches of anterior interosseous nerve. You have to talk about the palmar cutaneous branch, what it does, and about the recurrent branch, it curves upward and all that story, and finally the palmar branches. Yes, clear with the course? If you are clear with this course, you can proceed with the clinicals. So what happens at clinical? So we are going to talk at 3 major sites. One is injury at the elbow, then injury at wrist, injury at carpal tunnel, right? So we are going to talk at 3 important sites. Now, elbow is where, right, almost at the level of cubital fossa, yes, you have got no muscular branches originating. Now, if the injury is going to be right there, what is going to happen? Yes, the complete function of median nerve is going to be lost. Yes, what are the functions? At the median nerve, at the cubital fossa, it is going to give, or it is going to supply all the flexor muscles. Right? It is going to supply all the flexor muscles, which is going to cause flexion of wrist. So what happens? There is no loss of wrist flexion. In turn, the wrist flexion becomes weak. Now you will have a doubt. Yes, you told the median nerve supplies all the superficial flexors, and you also told all the superficial flexors are going to cross flexion of the wrist. But why you are not saying loss of wrist flexion? Yes, because median nerve is not going to supply one flexor. Yes, what flexor? Flexor carpi ulnaris. And median nerve is not going to supply the medial half of FDP. Yes. So because of these two, there will be some amount of flexion. So I cannot say there is loss of wrist flexion. Why I cannot say loss of wrist flexion? Because the median nerve does not supply the flexor carpi ulnaris and the medial half of FDP. So it causes some partial flexion. So wrist flexion is weak. Yes, we have covered about the branches of the cubital fossa. Then you come down. Then you have got the anterior interosseous nerve. Yes, then you come down. So what are the other things? Immediately leaving the cubital fossa, it is going to pierce the pronator teres, where it supplies the pronator teres. Also, it supplies the pronator quadratus, the anterior interosseous nerve. So again, that is going to be lost. So there is loss of pronation. I hope now you will understand why you should know the course of a particular nerve and the action. I am able to easily relate, right? Yes, there is loss of pronation. Why there is loss of pronation? Because the median nerve is injured at the elbow. What happens if the median nerve is injured at the elbow? Yes, if it is injured at the elbow, pronator teres will not get its supply, and the anterior interosseous nerve that supplies the pronator quadratus will also not get the supply. So there is loss of pronation. Yes. Then most important, I have put 2 pictures here. This picture, this phenomenon is called as benediction deformity. It is called as benediction deformity. What is this benediction deformity? Yes, a very important picture. Now, when a person is trying to fist his hand, okay, when he is trying to flex the digits, when he is trying to flex his fingers like this, that is called making fist, right? If he is trying to have the fingers fist all over the hand, then it is called fist, right? It's basically flexion, right? When he tries to make a fist out of his hand, he is able to observe that he is not able to he is not able to flex the fingers at the thumb, at the index, at the middle finger. This is called benediction deformity. So he is not able to perform the act of flexion at these three fingers, but these two fingers, they are doing it very comfortably. Such a representation is called benediction deformity. Now, why it should happen? Just think. Now, here you will be having the proximal interphalangeal joint. This is my distal interphalangeal joint. Only if the proximal interphalangeal joint and the distal interphalangeal joint flex, you will have fist formation. But here, if the injury is at elbow, yes, your FDS, your FDP, lateral half of FDP, both are not supplied. Only these two are responsible for causing the flexion of the the proximal interphalangeal, distal interphalangeal joint. Even distal interphalangeal joint, if you take it, is partially flexed. Why it should be partially flexed? Because the medial half is supplied by the ulnar nerve, but FDS is supplied by your median nerve, so you will not have flexion of PIP. Just observe the picture carefully. Distal interphalangeal joint is somewhat flexed, but if you take the PIP, it is not flexed at all. So it is because there is paralysis of FDS. So because of loss of flexion of, or because of loss or paralysis of the FDS and the lateral half of FDP, the flexion of the PIP and DIP is not accomplished. So there is this formation that is called benediction deformity. Next one, something called ape-thumb deformity. So the hand looks similar to the ape. So how it looks, just observe this picture. I want you to get to this portion. If you see, what happens to the thumb? As thumb, if you take, it is laterally rotated. Just observe the picture as it is laterally rotated. It is facing laterally. And it is adducted. Yes, if you take the thumb is adducted. So ape-thumb deformity is characterized by lateral rotation of the thumb along with adduction of thumb. Not only that, just observe the thenar prominence. The thenar muscles will flatten because it is supplied by the median nerve, the recurrent branch. The injury is at the elbow level. Yes, there is no point of talking about median nerve at all. So there is no supply to thenar muscles. Hence, there is thenar flattening. Right. So these are the points: loss of pronation, wrist flexion is going to be weak. There is benediction deformity. There is ape-thumb deformity. There is loss of sensations. Yes, because of the palmar cutaneous branch and even the palmar digital branches, there is loss of sensation. So these are the various presentations the patient will come if their injury is at the level of elbow. What happens if it is at the injury at the level of wrist? Yes, just get back to this picture. That is, he's talking about injury at this level. Yes, what will happen? You will we have benediction deformity? Will we have benediction deformity? No, we will not have benediction deformity. Why will not have benediction deformity? Because the superficial flexors are supplied right at the elbow level. Yes, they are given at the cubital fossa itself. So there is no need for no additional flexors, right? So it is going to take care. So you will not have benediction deformity if the injury is at wrist level. So what is the thing that we will see? Yes, definitely we'll see ape-thumb deformity. Yes, because the median nerve at the wrist level is cut, right? So only after it enters into the carpal tunnel, it gives us a recurrent branch. It is not going to happen. So that is ape-thumb deformity. Yes, done. Then as well, there is loss of sensation over the entire hand as well as thenar eminence. Why this point is important is because the palmar cutaneous branch is going to arise at the level of wrist, right? So there is sensory loss at the thenar eminence. So ape-thumb deformity and sensory loss at the level of thenar eminence is a characteristic feature at the injury at wrist. But will we have benediction deformity? No, we will not have benediction deformity. But if the injury is at carpal tunnel, what happens? Just imagine if the injury is at the carpal tunnel, First thing, very important, is no sensory loss at thenar eminence. Why is there no sensory loss? Because the median nerve gives rise to the palmar cutaneous branch before it enters into the carpal tunnel. Yes, nerve enters here. This is the carpal tunnel, but the palmar cutaneous branch is raised right at the level of distal forearm or the wrist. So you will not have any sensory loss at the thenar eminence, right? Along with that, you will not have any complete paralysis of thenar muscles, but you can have weakness of thenar muscles. And very important point is there will be tingling sensation or pain. So we saw till at the level of wrist there was complete sensory loss, right? But here if you take, the patient will present with severe pain, especially at the night time. You will suffer lots of pain. So how to identify this injury at the level of carpal tunnel? Now, what are the causes of injury at carpal tunnel? Why should the nerve be injured? There is because lots of pathological things. Okay, like for example, the synovitis, inflammation of the tendons there, or there's any fraction of the wrist bone, fracture of the wrist bones, etc. All those are some of the causes, right? So main thing is, appreciate this picture. What he's trying to do. Just observe once again. This is called as Phelan's test. Very important test, Phelan's test. Sorry. I'm sorry. I'm using writing pad, so that troubles me sometimes. So just do not mind. So just appreciate that this is Phelan's test. So what he's trying to do is, he's resting his elbow, right? So there is flexion of his elbow along with flexion of his wrist, right? So he's flexing his wrist along with flexion of the elbow, right? Now, how he flexes the wrist, just observe, he's trying to put the pressure. So there is a pressure is on each of the wrist, right? There is pressure on carpal tunnel. So when he does flexion of the elbow along with the flexion of the wrist against each other, against each wrist, then that compression is going to cause some pain. That is called Phelan's test. That is called Phelan's test, right? It's very important. Flexion of elbow along with flexion of wrist against each other is called as the Phelan's test. So if a patient is going to experience pain, then he is positive for the Phelan's test, right? He is positive for the Phelan's test. Now coming on to this is called Tinel's sign. This is called Tinel's sign. That is, if I am going to compress at the site of the carpal tunnel, then there is pain complaint from the patient. So if you see, yes, he has given some radiations, right? So if I'm going to press at the level of carpal tunnel, yes, there is going to be some pain sensation carried over the hand. It is called positive Tinel's sign, right? So this is about the clinical. So see, if I understand the course, right, first I should understand the muscles. If I understand the actions of the muscles, I know the actions, I know the course of the nerve, clinicals becomes very simple, right? I've very clearly explained you what happens with injuries at the elbow, at the wrist, and at the carpal tunnel. I hope you understood this video, and I hope I made this session a bit interesting, right? So if you have any doubts, you can put on the comment section. We'll meet you in some other video. Take care. Tata. Bye.